try to discuss a couple of cases and discuss the problems associated with the intermediate lesions. So we'll speak about the first case, which is a 51-year-old female who's been a hypertensive for the last 9 years under control with a significant family history, presented with possible cardiac chest pain for the last 1 month. There is no dyspnea. She has normal ECG as seen and good LV function. LDL is slightly higher with value of 156. Other blood parameters are normal. So I would like to ask the panelists what would be the appropriate next step in this patient. Mic please, mic to the panelists. So we have a 51-year-old hypertensive with family history and a possible cardiac chest pain. So what would be the next investigation to...
Yeah. Yes, this is a 51-year-old female with a strong family history and having hypertension as a risk factor and symptomatic. So better and with an elevated LDL levels, I would suggest to go for an angiography for this patient. To advise an angiography for this patient to know about her coronary status.
So if we look at the ACC or ESC, though not completely validated in our Indian population because we have a higher risk of ASCVD, she would fall into intermediate group, and we went ahead with CT coronary angiogram because it was just a possible cardiac chest pain and did not look like a typical angina. So as you can see, there is a 70 to 80% lesion in the LAD as well as RCA, and there is no obstructive disease in the L6. So what would you do when you have a CT with 70 to 80% lesions in LAD and RCA?
Yeah, this means in such a borderline scenario where the steno severity is borderline between 50 to 69%. So I would ask the radiologist for any high-risk signs or features of the plaque morphology, for example, any low attenuation or any napkin sign. So punctate calcification. So this would help us to maintain, to know more about the plaque risk, assess the plaque morphology better.
True, sir. True, sir. So we also did the same, but since we are also having CT FFR now in our hospital in-house, so we also have additional information of CT FFR along with the plaque analysis which you were mentioning. So the LAD lesion showed a CT FFR value of 0.77 and the RCA was just borderline of 0.82, and with respect to the high risk plaque characteristics which you were saying, posterior remodeling, low attenuation plaque and napkin ring sign in LAD lesion and posterior remodeling and low attenuation in RCA. So these are the features. One is positive and the other is negative. So what would you do now at this point?
Yeah. Can you just go to the previous one?
Yes, sir.
Here, if you see, the calcification is there in the LAD, in the proximal and mid segments. This CT angiogram wise, it looks like moderate, and the tightest lesion in this frame is in the junction of the mid and distal LAD. The management mainly depends on where is the lesion, whether it is proximal LAD or mid LAD, because if it is in the mid to distal LAD, probably you can consider even managing it medically, the patient is not symptomatic. If it is proximal LAD or ostial LAD, you have to be more careful and critical in taking the management decision. And here CT-FFR is there and LAD it is significant. So what's the important here is we have to understand how strong CT-FFR correlates with the cath lab FFR. That is the question we want to know.
Also wanted to know, sir. These were the early days when we had the software. So obviously we wanted to confirm these findings. We went ahead with invasive angiogram. So almost similar findings were seen in invasive angiogram as well. And then we have done RFR as well as invasive FFR. RFR was 0.89, again just borderline, and invasive FFR was again 0.82. And also with regard to the plaque analysis also, we have
Again, can you go back to the one frame, the previous slide? Next.
This is the next one, sir.
If you see the angiogram, you can see the tightest lesion in the conventional angiogram after the septal, in between the two diagonals. Angiogram wise, it is the tightest lesion. But all of us should remember that conventional coronary angiogram is only a two-dimensional thing. It is not a three-dimensional thing. So you did OCT, definitely it is useful. And based on this FFR and RFR values, you can manage it medically if the patient is not symptomatic. And the
OCT had the minimal luminal area of 1.77, sir, with the area stenosis of 72%, and it was also a fibry fatty plaque, and you can also see cholesterol crystals at 7 o'clock position as well as 11 o'clock position. So we have vulnerable plaque characteristics on OCT as well as CT coronary angiogram with borderline FFRs and CT FFR. So again, we brought up this case because it was a real challenging case or a diagnostic dilemma. We don't know, everything was borderline. There are certain high-risk plaque characteristics. Physiology was borderline. We never knew, and I think probably leaving on medical management is also an option. So we had a shared decision making on this, sir. As per ischemia, we can obviously leave the patient on medical management and do aggressive lipid lowering therapy and antiplatelets. We had a shared decision making regarding the same with the patient family, the pros and cons of doing such a thing. And finally, we went ahead with stenting. But the point which we wanted to make from this case is, as sir was mentioning in the morning also, intermediate coronary lesions, even after multiple investigations, also sometimes become a difficult decision to make. And nowadays, the upcoming concept of CAD imaging and triple aim of CTCA, where you know the anatomical stenosis severity, you know the plaque characteristics, the high-risk plaque characteristics, and physiological assessment. All the three combined together would help us, the interventionalists, to make a better decision rather than just simply a CT coronary angiogram or just simply an invasive angiogram, which is absolutely probably not at all helpful in these intermediate lesions. So after everything, though we have stented this case because patients also wanted but the same case on the right side, where similar intermediate lesion was there in the mid RCA, the CT-FFR was negative, the invasive FFR was also negative, and even the OCT did not show any high-risk plaque characteristics, nor the area stenosis was also significant. They were able to comfortably leave the RCA and only stent the LAD in this case. So just wanted to show the complexity associated with these intermediate lesions and how the upcoming technology of CT-FFR and the plaque characteristics are helping us to make better decisions than the previous years. So I'll move on to the second case. If anything the panelists want to say.
They have more of a mature fibrous plaque.
And also, like as I was saying, these were our initial days. But now, since we have validated these CT-FFRs with many invasive FFRs now, probably at this time, after the CT itself and the FFR being negative, we would not have even gone with the invasive FFR in this case. So that's what it is helping us. Probably we are trying to learn more and more from these cases.
Managing these patients on high dose of statins to passivate the plaque could also be one option. Suppose, as you have explained to the patient.
Optimal medical therapy would definitely play a role, whether you stent it or not stent it.
Yes.
Yes, sir.
Can you please play RCA OCT again? Angiographically, the lesion looks long lesion with conventional angiogram also it looks like significant, but FFR is negative. So you have to believe FFR when you do FFR. The lesion is long. If you see the OCT, here also the lipid burden in the plaque is big. And if you want to have a holistic approach in such cases, you have to bring down the lipids at a faster rate. You have to consider injectable lipid lowering drugs in such scenarios.
Even this patient was having LDL of 156 We have kept the patient on statin as well as histamine. The latest follow-up value of this patient was less than 55. It was actually 45. So we were comfortable. Otherwise, we are also giving PCSK9 inhibitors in such population as well.
But again, to conclude, the clinician is the best judge. He has to take all the things into consideration and take a meaningful decision.
Yeah, the points are well taken. Only thing is now the LAD. Your OCT shows 1.7
In LAD.
by any LAD.
Yes.
So any standards, so it is significant. And the other thing is it's a very long lesion and atherosclerotic burden seems to be high. Number 3, the proximal LAD calcification extending into the left main also. So all these factors put the patient on high risk, and the more important, like your OCT, if it were to be something like around 3.5, probably very aggressive lipid lowering and all. But leaving this in an active patient without doing anything, we were not very sure. But still, we gave the shared patient decision, and that's how he went for a PCI. Yeah.
It's the right approach.
I'll be quick with my other cases. I think we are short of time. So the second case is a 62-year-old female diabetic with chest pain with diaphoresis since 3 days. ECG echo were normal, blood investigations were normal. LDL was 49. She was on statin previously. She was using for diabetes. One physician has written it. So now she presented with chest pain with diaphoresis since 3 days, and troponin was negative. So what would be your approach now again?
Yeah, this patient had done maybe an angina, means typical angina over the 3 days period, the drop negative and unstable angina. In this patient, suppose if you do have an CT modality, that I would suggest him the CT. That would be my first option, I think.
Yes. So as per our hospital protocols as well, we are sorry.
In such scenario, the most important thing is you have to repeat the troponin after 2 hours.
Serial troponin is negative.
If serial troponin is also negative or same, then with chest pain and diaphoresis, you have to think of non-coronary options also. Sometimes it may be an aortic dissection or a pulmonary thromboembolism. So every chest pain with diaphoresis need not be coronary artery disease.
Yes, considering that other causes are ruled out, so if it considered as coronary only. So as per our hospital policy, we went ahead with CT coronary angiogram. So you can see with the calcium score of 235, we have an intermediate lesion again in LAD, proximal to mid. L6 lesion was tight, and the CTFFR value for this LAD was 0.72, and with plaque characteristics of posterior remodeling and low attenuation plaque. So what do you think should be the next thing? How would you approach this?
In this, we are getting out of the 4 the signs of the VP, vulnar plaque. Out of the 4, 2 came positive. It's a low attenuation plaque and posterior remodeling. So I would suggest to go for a conventional angiogram in this patient.
So the conventional angiogram, as you can see, the short left main with the LAD in cranial view, you can see there is a hazy looking lesion in the proximal to mid LAD. And we have also, by this time we were slightly convinced with the CTFFRs, and we have validated also. So we did OCT just to see what the hazy looking lesion is, whether it is some other plaque rupture or something, or just calcium which is looking like that. So we have an MLA of 1.56 in a vessel which is almost 2.75, and OM1, OM2 were significant, as you can see, and also distal LCX, though it's not clearly filling in the cranial view, the distal LCX was also significant. So with the information, since LAD was significant and 2 branches of OM as well as LCX significant, we actually had the information of intermediate lesion, which was confirmed on CT FFR that it is positive, and with high risk plaque characteristics and a fibroflatty plaque on OCT. We have gone ahead actually with CAVG, since he was also a diabetic also with the major vessels involved, and he was given grafts to LAD and the patient is doing good. So similar case, third case, again we wanted to show cases where initially we have validated and then we now have all the information with the CT itself, and our invasive assessment was almost similar to what we are seeing on CT, and this is helping us a lot. Even before taking the patient to cath lab, we know all the information and how the lesion is, what the plaque characteristics are, and what the physiology is. So this is the controlled LAL. This patient on assessment actually showed a significant disease in LAD, but the LCX osteoproximal was 50 to 60%. I'll show you the angiogram as well. So it is around 50 to 60% osteoproximal LCX. RCA was not a big vessel, but if you can see the CTFFR, the value was 0.80. So we were not sure because angiographically it would look like 50-60% lesion only. We also did the OCT. So the vessel, as you can see, is easily 3.5 vessel, and the MLA of this lesion actually was 2.6 millimeters square. For a 3.5 vessel, it would give a area stenosis of 76%. Also, this patient had some thrombus seen in the osteoproximal L6 as well. So with all the information, sometimes though we are conventional thinking of 50% lesion might not be significant, but the CTFFR actually showed a value of 0.8, and that has been confirmed on OCT as well. So we have encountered such cases where many of the conventional thinking of ours have changed after looking into all the characteristics, and also CTFFR is helping us a lot. So we just wanted to show these cases, how these cases have helped us a lot. And I'll not go in much into the literature.
Nobody would expect a thrombus in LCX looking at this angio.
Yeah.
And so surprises are also seen hazy. So surprises are also seen sometimes with this when you're looking at combination of things. Both the FFR and imaging nowadays, though you have to be selective, but in proximal vessels, we should not think twice before ruling out anything, because patient can land up with LCX complete occlusion. There could be some erosion or rupture, which is responsible for the thrombus, and she may land up with inferior MI. So this has helped us. So that means still the cost, everything, how do you balance it is the most difficult thing. Now we are finding, we know most of the things. Most of the things we know that 20% chance that there is a problem. The problem is with the patient's trust and then money.
So CT. Sir, again, sir, LCX was significant, OCT wise. LAD was significant. It's a large LCX. So we have done CAVG.
Okay.
Yeah. Non-dominant RCS. So we wanted to emphasize that CT is now becoming a one-stop solution or one-stop shop for all. And with more and more learning, we have understood that the value of CTFFR, just a single number is not what is important, but you should take the things into totality. Like what is the vessel territory? Is it an LAD or a non-LAD? Is it a proximal vessel, as you were saying, mid or distal vessel? And sometimes delta FFR, the drop of FFR value across the lesion also sometimes matter, and studies have come up saying that 0.12 is what is considered significant. And the plaque burden which we get and the high-risk plaque characteristics on CT are helping us a lot. And so the strength.
You are seeing that slope of the drop also.
Yes, slope of the drop. Yeah, I think the not included, sir. Actually. Show the stop. Yeah. Just like the invasive FFR, the delta FFR, the sudden drop in the FFR value on the slope helps us saying that there is risk. Obviously, you give endosin, you put a wire, and those associated risks are negated. And CTFFR in studies has shown to have a very good negative predictive value. That's what we wanted in these intermediate lesions, and it has a good negative predictive value. And CTFFR, as I was mentioning, is not a continuous variable. It indicates a continuum of risk, and you take other factors into consideration and then decide on your plan. And ACC/AHA in the 2021 guidelines has given a class 2A recommendation for use of CTFFR in an angiographically intermediate lesion. One major thing which has been there till now is high cost associated with CTFFR, because heart flow costs a lot and it's not feasible for in our setups to do. But now with the upcoming CTFFR, which is on site and which doesn't add any cost to the CTFFR, so the thing of cost is gone now. And the second thing, requirement of high quality imaging with the old CT scanners which are less than 64 detector is the problem thing. But now almost all the major centers have CTs which are more than 64 row. So that also doesn't become a major problem. And probably this is the time where we can safely say that CT is now going to be the one-stop shop. So I would like to conclude this intermediate coronary lesion session saying that they are commonly encountered, they are ambiguous in angiography, making the clinical decision very challenging. Anatomy alone is definitely not enough. Physiological assessment definitely helps in knowing the lesion significance. CT-FFR, the physiological assessment with CT, helps in to getting more insight about the CT angiogram lesion severity. And we have shown real-world use case of CT-FFR, and this helped us in solving the ambiguity, and it helped optimizing the patient care. And tailored approach combining all the CCTA features help us in making. Finally, the problem with intermittent coronary lesions is we are always in dilemma and we cannot confidently tell a decision. Probably that decision making is what CT is helping us. And as I was telling previously, triple aim of CCTA, that is anatomical severity assessment, high risk plaque characteristics, and physiology are going to stay, and they are going to be the future. Thank you.
Manohar, good presentation.
Thank you, Dr. Ram.